Welcome and thank you for joining us in the session NCD Patient Journey. Who defines it? Are we missing key touchpoints for intervention? Moderated by R. Narendhar, Vice Chair at the Indian Alliance of Patient Groups.
Thanks a lot to all of you. So good day to all of you. So we are in various parts of the globe. So I think that is the most appropriate way to greet all of us. So patient journey in LMICs is the overall topic that we are going to discuss about. And we need to also analyze and come to a conclusion. Who defines it? Are we missing some key touch points for intervention? So that is going to be our topic. So as all of you know, people with NCDs face lots of challenges. And non-communicable diseases has been the largest cause of morbidity, and 75% of fatalities happens in this arena. And this has been due to limited healthcare resources in LMICs and lack of access to accurate information, poor health-seeking behavior, and also some common causes like social, economic, and cultural conditions, which play a major role in this. And these influence the care pathways very much. And patient behavior gets affected, and also the patient journey. So when we talk about the patient journey, it starts with the essential awareness about the disease, health problem, and the need to seek healthcare support. And also understanding this aspect shall sure give an insight of patient's experience, preferences, and outcome of the disease, as well as the treatment care pathway. So thus the possible key touch points, as we have authored one in an article, we concluded that the key touch points would be awareness, knowledge, and risk factors of the disease, and need for screening and risk assessment, decision to treatment after right diagnosis, available treatment options and access, and adherence to treatment and its long-term management. To keep healthcare patient-centric and allowing self or guided management following a right care pathway for better health outcome. So understanding these touch points will allow us to know the opportunities by prioritizing requisite interventions, and also devise strategies to improve patient journey, integrating patient's perspective. And there are also some handful of solutions there, like the recent digital world offering a myriad of solutions. And I would like to hear from my fellow speakers on those options available. So with this introduction, I now introduce my fellow speakers to share their wisdom and experiences. May I now invite Dr. Chandrasekhar. So Dr. Chandrasekhar Potkar is the Chief Medical Officer for Pfizer Upjohn Business in emerging markets. He is currently responsible for medical organization in emerging markets and setting up medical and scientific strategy for Upjohn across Asia and Latin American regions. Previously, he was the regional medical officer and led Asia Pacific region for Pfizer, established health business where he led a medical team across the region and provided strategic medical support. So personally, Dr. Potkar has over 26 years of professional experience, which is quite commendable and really impressive. And he has been a pharmaceutical physician, and throughout his career, he has taken on leadership roles of increasing responsibility in academia and industry across clinical research, regulatory, and medical affairs. And Dr. Potkar has extensive experience in setting up of startups and leading service delivery. So Dr. Potkar earned a bachelor's as well as a master's degree in medicine from Mumbai University. He then completed his MBA at Deakin University, Australia, followed by a master's in health sciences from George Washington University, UK. So I now invite Dr. Potkar to give his wisdom to us. Dr. Potkar.
Thank you, Mr. Chairperson. And really, at the outset, let me thank IAPO and the Asia Pacific Patient Congress for inviting me and giving this opportunity to me to join this esteemed panel. I'm very happy to see we have patient representation on the panel, so it will be an interesting conversation on a topic which is so dear to my heart, the NCD patient journey. So very, very happy to have this conversation with all of you. I'm going to put forth 3 points for us to start the conversation. The first point is around the silent pandemic of non-communicable diseases that we see in low and middle income countries. The second area that I would want to talk about is around the NCD patient journey and why that is a very useful framework for us to develop solutions. And the third one is essentially around the solutions itself. So what kind of solutions that we can look at? So these are the 3 broad areas I would quickly cover in less than 5 minutes for us to really get into the further dialogue. So let me start with the first one, the silent pandemic of non-communicable diseases in LMICs. I think all of us are very familiar with the impact that non-communicable diseases are causing in our countries. 7 out of 10 deaths are caused by NCDs. Every 2 seconds, there is a death which is premature death between 30 to 70 years of age of population at large because of NCDs. More than 50% of our countries are off track. They are not likely to meet the objectives which are laid out in Sustainable Development Goals by WHO 3.4. And if to make matters worse, really, we have our exposure to COVID pandemic, and this is actually further derailed the progress which has happened in last couple of decades in just 1 year. We are practically reaching the first anniversary of the pandemic. But if you really see, the overall impact is significant disruption of the NCD services in our part of the world. More than 50% cases are in emerging markets, low and middle income countries. More than 50% deaths are in low and middle income countries. So this only highlights the impact and the problem that NCDs are going to cause in our countries. So why is NCD patient journey a very useful framework? Earlier in the year, we, along with IAPO, we developed a NCD patient journey in 5 stages, from awareness, screening, diagnosis, treatment, and adherence. The 5-stage framework, which we labeled as MAPS, mapping patient journey for driving actionable solutions. That is a useful model, and I can give you one example in case of hypertension, patients with high blood pressure. If you take a look at emerging countries, there are about practically 1 billion patients with high blood pressure. If you look at how many of these are aware that they have high blood pressure, less than 40%. How many of these are treated? Again, less than 40% of those who are aware. And finally, if you look at how many of them are getting controlled on the blood pressure medications, less than 10%. If you look at this funnel from 1 billion patients who have high blood pressure to the patients who are getting controlled, that shows the leakages which are happening around the patient journey. What does it tell us? It tells us 2 things to my mind. One is that treatment alone is not going to solve the problem. We will have to invest in awareness, we will have to invest in screening, we will have to invest in increasing diagnosis and control rates. That's lesson number 1 for us to really see how do we address this issue. And secondly, a solution cannot be one size fit all. The situation might be a different situation in Malaysia. It might be very different in Egypt versus it can be very different in Mexico. We need local evidence what exactly is the issue? Is it an awareness is an issue? Is it the screening is an issue? Is it the control which is the issue? So we will need local evidence for us to really diagnose the root cause before we start planning the solutions. So that's my point number one. And NCD patient journey really provides us exactly the diagnostic based on local evidence to plan the solutions. The third part is essentially around solutions. What can be the solutions? So the way I would propose the solutions to be grouped under three broad areas: the solutions which are very patient-centric, solutions which are provider-centric, and the solutions which are policy-centric. So if you look at these three broad themes or categories of solutions, for patients, we can look at, as Narendhar mentioned, we can have digital solutions, self-empowerment toolkits. We can have health promotion. For practiced or provider-based solutions, we will need to see how do we strengthen primary care as one of the key stakeholders, given the risk assessments, integration of care happens at primary care. So how do we strengthen primary care as a route to solve this problem of patient journey? And third would be around policy. So at policy level, again, there are several connotations which come in, whether it is health inequities, social determinants of health, implementation of the policies. So there are a host of things that will get factored under policy solutions. So that is my initial opening. And I'm looking forward to the conversation. I'm sure we will have a good conversation as we go forward on various aspects and facets of patient journey in NCDs. Back to you, Mr. Chairperson.
Narendhar, you're on mute. Narendhar, you're on mute.
Sorry. So thank you, Dr. Potkar, for that very succinct and live wire out framework for us to discuss. So now may I invite Dr. Fatima Lorenzo to speak on her own views from our country. And before that, I would just give her a small introduction. Maria Fatima Garcia Lorenzo is her full name, and she advocates for patient rights and is engaged in health policy development. And she is the president of the Philippines Alliance of Patient Organization, which is an umbrella body of 32 disease-specific patient groups. And she is representing 1 million patients nationwide in a country. And she is member of the Department of Health Technical Working Group on Patient Safety and is an advisor of hospice in Philippines. And she was chosen by the Union of International Cancer Control as one of the patient leaders in the Asia Pacific Patient Leaders Mentoring Program. Fatima is also Philippines representative to the Duke NUS Center of Regulatory Excellence Coalition to accelerate patient engagement in the Asia Pacific region. So, Madam Fatima, yeah.
Thank you. So just a disclaimer, I'm not a doctor, so I'm a layperson. Okay, so the topic assigned to me reads, today cancer patients face a complex range of choices across the full spectrum of healthcare, from diagnostic radiotherapy, surgery, chemotherapy, monoclonal antibody, and other choices. How do they navigate these pathways and touch points? So first, what are the touch points of a cancer patient's treatment journey? And I will use the framework by Dr. Potkar, what he mentioned a while ago. These are disease awareness, screening, diagnosis, treatment, and adherence to long-term treatment. And these are some ways cancer patients in low to middle income countries navigate through these touch points. When it comes to disease awareness touchpoint, health ministries together with cancer advocacy groups conduct cancer awareness programs, and each month of the year is dedicated to a specific cancer type, and activities or programs are implemented in schools or in local government levels. Cancer patients may get to know more about their disease through health promotion materials using multimedia platforms. Cancer patients also search various websites and turn to social media to know more about their disease. When it comes to screening, some patients are able to undergo screening through local government unit cancer programs, such as cervical and breast cancer screening. Cancer-related NGOs or non-government organizations also offer screening programs to their beneficiaries. Other patients who can afford use their personal health insurance for screening procedures. When it comes to diagnosis and treatment touchpoints, cancer patients base their decisions heavily on their capacity to pay. And if they are unable to pay, they depend on government support, such as universal health insurance or cancer treatment packages, or subsidies given by the Department of Social Welfare and Development, or they ask help from their local government leaders. There are also instances when they need to sell their properties and borrow funds from relatives and friends. There are, again, non-government organizations who provide financial support to cancer patients. In the Philippines, with the passage of the National Integrated Cancer Control Act, the patients are looking forward to the establishment of a cancer fund. And when it comes to cancer patients' adherence to long-term treatment, this is dependent on treatment outcomes, patients' economic status, family support, and personal choice. It is important to understand that the cancer patient's entry into the continuum of healthcare is not only through one touch point, but through different touch points and at different timelines. Their entry may be dependent on factors such as personal preferences, family background, education, economic status, or cultural influences, to name a few. Cancer health providers, therefore, need to consider these complexities and move away from a one-size-fits-all approach. Patient-centered care is the recommended approach. Patient-centered care is where patients are partners with their healthcare providers. It is a relationship wherein the healthcare provider empowers the patient to be actively engaged and share decision-making at any touch point of care. The patient, however, needs to have the necessary knowledge about his or her disease in order to participate in shared decision-making. In PAPO, we encourage our patient members to document their experience in a journal. Information such as name and dosage of medicine, time they took the medicine, how they felt when they took the medicine are examples of what are handwritten in this journal. Patient may also describe their mental and emotional state during the treatment journey. It would be very helpful for both the patients and healthcare providers if this patient journal will be transformed to an electronic or digital patient experience data. This patient experience data can be shared real time with healthcare providers. So when patients weave in and out different touch points of care, vital patient-driven information is not lost in the system. Reminders and information from cancer healthcare providers using mobile phones can help cancer patients adhere to long-term disease management. Pharmacists in local drugstores can also play an important role by conducting medicine counseling. In the Philippines, barangay healthcare workers play an important role in informing and delivering community health services. The barangay healthcare workers can go to the patients' houses to monitor compliance. Unfortunately, the barangay health workers are only given allowances. There is a need to professionalize barangay healthcare workers for continuity and sustainability of cancer programs on the ground. One important but more often overlooked support for patients' adherence to long-term treatment is the value of educating and involving all members of the household in the treatment care. Psychosocial support and family counseling helps the patient not only for adherence but in the whole treatment journey. We actually need to include mental health in all touch points of care. So there is a need for more psychologists, counselors, and mental health practitioners to take an active role in the continuum of care. And this brings me to discuss the importance of palliative care. Palliative care is still not widely accepted in Southeast Asian countries. Because when people hear about it, they associate it with end of life. It was only in these past few years when palliative care changed its meaning to an improved quality of life for the patient, family, and caregivers. And it may be given in all touch points of care. Some countries have not integrated palliative care in their healthcare system. In the Philippines, the integration of psychosocial intervention, palliative, and hospice care are in the provisions of the Universal Health Care and the National Integrated Cancer Control Act. And now the Department of Health, together with Hospice Philippines and Philippine Society of Hospice and Palliative Medicine, are finalizing the Palliative and Hospice Manual of Operations and Procedures, which will hopefully be cascaded to all hospitals and healthcare centers in 2021. In summary, we have to have conversations on the following recommendations to help cancer patients navigate touch points of care. 1, advocate for patient-centered care approach. 2, create policies which will enable the use of digital patient experience data. 3, involve allied healthcare workers in the community, such as the local pharmacists, psychologists, and counselors. Professionalize barangay or community health care workers. And 5, integrate palliative services in all touch points of care. Thank you. Over to you, Chair.
Thank you, Dr. Fatima. That was a very wonderful rendition of your work and also a window about the patient journey in cancer patient perspective. And also you touched upon the need for palliative care. That was a very eye-opening experience for one to understand and pursue. So now I invite Mr. Kawaldip Sehmi, who is the CEO of IAPO and needs no much introduction because he has been the pivotal force between all of us, and today we are here because of him. So with this very brief introduction, I invite Dr. Kawaldip to say his few words about his experience.
Thank you very much, Narendhar, Chair, Dr. Potkar, and Fatima. I think, Fatima, you've set me up very nicely to follow on what I have to say. And I think, as you know, what Dr. Potkar said, we were looking at 5 touch points, and they were about awareness, screening, diagnosis, treatment, and adherence. But then, very nicely, I think with great foresight, he had included that all this should be integrated within palliative care along the care continuum pathway. Now, we are in India, and I will, as a former cancer patient, I would have missed this opportunity not to raise this issue, because I think palliative care, from my perspective, is very important. Now, the availability of morphine and palliative care in India, what is sort of nicely said by Dame Cicely Saunders, who first looked at this, it's an enigma wrapped in a paradox. Here is India, who has a great legacy of producing opium. In fact, the British East India Company made it a primary product for its exports. The same product actually raised the war in China, the Opium War in 1800s. So opium brought both parts of Asia together, and yet, if you look at how high quality palliative care morphine is produced, India is the leading producer of it, and most of its product is exported, but yet patients in India don't have good access to it. So as a touch point, I think palliative care for an Indian patient, from a patient with cancer relief, others, it's very important to address this. point of view. We know that the reason some of this is happening and it needs addressing very carefully. We have rights of patients. I think within the 1992 pain relief and availability of morphine that was designated as a national cancer control program in India, but also elsewhere in many countries, access to palliative care has become one of the most important aspects of patient rights. And yet, when we do come to see how that is being acted, I think many of the countries have got problems. Many of the governments in low and middle income countries have attributed this within the national narcotics laws. As you know, when WHO with the what they call the Securities Council and others met, they just wouldn't move the presence of opiates for palliative care out of the drug regulation. It was kept in a criminalized fashion within that. And patients, I think, are being felt as if accessing this is they're doing something wrong. And then we know from aspects in India as well that in '95, the WHO and the Ministry of Health in India looked at policies governing availability of opiates in the class of morphine especially. And what this reveals that very few people understood all the requirements. I think health professionals, policymakers, people practicing on the ground didn't understand how morphine should be available. They set up the India Morphine Availability and Control Committee. Again, we were finding that patients were not understanding, or health professionals weren't understanding how possession license was to be manage a quota, how the quota system worked, how the import license, possessor of drugs, other things were working, how to look at interstate export between state to state, and license to transport drugs. All this has created uncertainty, not only in India, but across many countries right now. We find that if this patient journey has to be speeded up, and if this patient journey has to be made comfortable, if I can put it, then we must look at the first touch point. That's about palliative care, that it's very important for us. I think it's something that's essential. Then if I move across above the last touch point, as I say, we then need to look at awareness and screening. I think this is something we all know now that is very important in this journey. What has happened is our journey has been disrupted. Our journey has been waylaid by COVID. Not only has the journey been disturbed, many of the care pathways that we had mapped out are in ruin. It's almost like traveling in the Himalayas during the monsoon season, that you can never be reassured which road is going to have a landslide, and your journey will be disrupted. And this is what has happened. Our pathways have had landslides, and I think many of them are now not operational. We know that other touch point that we are really very concerned about is that we need rapid diagnosis, and that is really important. That if the diagnostic centers are shut, we don't have access to them, that makes double difficulties for us to make sure that we get the treatment that we need at the right time. And lastly, I think the touch point that we had talked about, adherence, we have said there are much out there by way of Fitbit apps, which are used now to prompt people to take the correct medication at the right time, and also telehealth to support them. But all this needs to be accessible for patients. And I think it's very important that we do that. And if you combine all these 5 broad touch points into one issue, I think the issue really is about political will to help us review how we deal with NCDs, how we deal with the patient perspective, and how this patient perspective is included in that. So far, the NCD policy and machinery has really concentrated on the bigger public health issues. It was more about making sure banning smoking, making sure the sugar, obesity, all those levels addressed, but very little was being paid, or very little attention was being paid to secondary prevention, which is, again, as Dr. Potkar put it, really an issue of primary healthcare and the Almaty charters, that this needs to be there. Once you're diagnosed with a NCD, then it's very important to prevent it becoming aggressive, carry on into developing something more serious, and that needs urgent attention, which will be protective prophylactic treatments. There are lots of those, and ensure that the patients access this and are aware of this. And the last point of our journey is, I think, the social acceptability to make sure that we are able to talk about NCDs. One of the things we found when we were trying to promote this Congress within India and Asia Pacific, we found that we were having very few social influences out there. And what this actually meant was there were very few patients who actually talked about the conditions, were happy to share their experience. In my case, I wear a colostomy bag, and I can tell you that the best example of where a patient is talking about this has been young people in the US, in Europe, who are happy to show you how to exchange the bag, and yet I can't find anything in Hindi or Urdu that I could use in the Asia Pacific content. So we would like to see those things addressed so that patients can come forward and use this medium to talk. And overall, I think we are now in a position where we all have to get together. As I said, get together, it should be in global solidarity, and make sure that we go back on these landslided paths, clear them up and repave them with care pathways that are reflective of the patient journey, sensitive to our needs, has got the resting points and the support that we need along the line. And they don't happen to be care pathways that are administratively kind of convenient or efficient for them. The pathways have to reflect our lives and complexities of a disease. There's nothing within our reach. We have the technology, we have the people. All that's now we're missing is the will, and the political will has to come in. Thank you, and allow you to now progress this conversation with other participants. Thank you.
Thank you, Kawaldip, for very wonderfully summarizing the kind of problems that we are faced with when it comes to regulation, and also the problems when it comes to all other touch points. So now that all our speakers have put up very good points, more highlighting the problems. So now can we move our discussions towards more talking about some of the possible solutions, so that we give some take-home message at the end of this discussion. So I would again invite Dr. Potkar to give us some viewpoint on this three-pronged strategy he was talking about, and how do we just look at more viable and workable solutions. And when we are talking about this, we should also bear in mind that in LMICs, the health-seeking behavior is a little different. And once again, when we talk about health-seeking behavior, the barriers to healthcare, which was highlighted very well, needs to also be borne in mind. And we should also think about those people, like in my case, I work for Alzheimer's disease. And if you see the people accessing healthcare system, in India, we have two kinds of healthcare system which are predominantly available. One is private healthcare, another one is government-based healthcare. When we talk about government-based healthcare, the number of people getting access to it is very meager, and it is around 2 to 3%, and rest 56% goes to private medical facilities. And there is one big lot which are let out. 33% of people don't seek any kind of health care. So what do we do, and how do we deal with that kind of a situation? So if our solution can be little more focus towards that, that will be a great help.
Thank you very much. I'm happy to communicate some of my thoughts around what kind of solutions are possible. I think before we get into solutions, one point which I just want to highlight is when you start with this patient journey, 5-pronged patient journey, and if you look at, as I mentioned in the initial comments, if you want to know exactly what is the root cause in a specific country, you would normally rely on evidence. What is the evidence that is available? For example, in India, in cases of hypertension or in case of depression or take any non-communicable disease, we need data so that we can bring in stakeholders to target that action. But we don't have credible data, and that is the first point that we need to solve for. What we need to do collectively as the community of stakeholders that is invested in this cause is how do we generate the credible data for each one of our key non-communicable diseases in each one of our countries in LMICs, which is published data so that the decision makers can rely on that data. And this is exactly what we have started doing in our own baby steps. We have taken some disease areas, we have taken a few countries, we have prioritized them, and we have started talking to stakeholders to get that data mining, publications, and this exercise needs to happen on a periodic basis. It is not a one-time effort because the situations will change and we will need to see how our interventions are effective. So one is evidence is first part that we need to do properly, even before we get into the solutions. The second part is, are we involving all the relevant stakeholders in developing the solutions? So I really liked what Fatima described from patients and the way patients are capturing the patient journals, the very specific details. I think we need to definitely involve. A solution cannot start with only providers. It has to involve patients, caregivers. It has to involve the other interested parties. I would also go beyond our conventional stakeholders like governments, NGOs, multilateral organizations and all. We should really involve other atypical stakeholders like social marketeers. If you really look at what are the risk factors we are trying to address, we are trying to address diet, physical activity, tobacco smoking, alcohol, pollution. These are the top 5 risk factors which cause majority of the non-communicable diseases. If we have to address this, we will have to really include other stakeholders which potentially can introduce nudge, behaviors, changes, those types of interventions. And that can happen through social marketers, that can happen through implementation scientists, people who do operations research. These are the kind of stakeholders which need to be involved in developing these solutions. So that is the second part. And my last part is essentially we need to operate in a partnership model. No one stakeholder can do it alone. It has to be a stakeholder partnership, whether it is public-public, public-private, whichever model works. Partnership is a means to an end, and we need to really operate in a partnership model. It's not a global partnership that will work. We will have to have very clear local solutions which are diagnosed based on the evidence, and partnerships which will drive at a specific country level. What will work in Philippines is not going to work in Malaysia versus what may not work in India. So we will need knowledgeable local partners to help us drive these solutions around patient journey. So these are some of my broad ideas around solutioning perspective. I'll give it back to you.
Thank you, Dr. Potkar. So now I invite Madam Fatima to talk about little on the prior to getting NCDs or anything there, like Dr. Chandrasekhar briefly touched on the risk factors and how do we just look at risk factors so that even before somebody gets NCDs, how what are the kind of precautions one has to take. So if you can talk that as a solution, that will be really helpful. Like in your case, because you are predominantly dealing with cancer patients and palliative care, if you can talk about the risk reduction engaged in these two arenas, that will be really helpful. Dr. Fatima.
Okay,
Yeah.
thank you. Well, in the Philippines, health promotion, they are talking about health promotion, and actually I was also involved in the tobacco control movement. And so one of the activities or strategies was the putting graphic warnings on the cigarette packs, all that. So that's one. And then another one was also ordinances by the local uh, chief executives regarding a total no smoking. It's a ban, really, no smoking. And even our president declared no smoking areas in most parts of the country. So Kawaldip was talking about political will. So in terms of the no smoking, in the smoking, I believe that our president had that political will, and it happened that really um, smoking was lessened. But then, unfortunately, the cigarette manufacturers became creative and went into vape. so, that's the thing. It has to really be a whole of society, whole of government approach, a total war on this, because they will always come up with something creative. And unfortunately, statistics have shown that yes, it has decreased, but not decreased enough for it to have really an impact with regards to risk behaviors. So a risk for smoking, at least there. So I also wanted to say that it is important because our patients vary. So most of them really don't have education or come from low economic group, that there's really a need for patient navigators. Patient navigators, like in the form, or like I mentioned, barangay or community health workers, who at one point, maybe at the beginning, will handhold the patient into the journey until the patient is capacitated enough to take an active role in his or her health care. So I think that's a doable um, solution, that maybe we could have patient navigation programs or capacity building on how to become effective patient navigators, so that we can bring the patients through the journey smoothly and achieve our goal for different touch points of healthcare. So that's it for me. Over to you, Chair.
Thank you, Madam Fatima. Yeah, now I go to Kawaldip, and Kawaldip, being an expert and exponent in public policy advocacy, I would want him to little more detail on the solutions that he see from public policy advocacy perspective, because that we are all LMICs and we deal with our own government. So, what would be your solution for taking patient journey and these touch points as key input for policy advocacy? How do we
Okay.
do that? So, yeah.
I've got the twin caps today. I'm also the director of this program, so I think my time is limited here now. What I would suggest is please contact me individually or in group. I can organize another Zoom and let's talk about what it needs to be there. But as I said, we need to look afresh at how the legislative policy, practice, standards and ethical frameworks exist, because I think COVID has given us that time to reset the button. And that's what we need to reflect on. And Fatima, thank you very much for bringing those pathfinders, and God bless them. I think they are needed in our systems. They're the people who handhold and walk you through from center to center. Until we have integrated our healthcare systems, we'll continually need pathfinders. I couldn't find my pathway through this. I don't know what happens to an ordinary citizen walking through there. So I think, Narendra, with that, I'll conclude. And if you could close the session and we move on. Thank you.
Thank you, Kawaldip. And we have 7 comments from our audience, but none of them are questions. They are more like kind of suggestions and some real comments. And so I would not get into much into that, and I'll just give my concluding thing. So I thank all my fellow speakers who shared their rich experience covering the essence of patient journey in true LMIC context. And in the past, patient journey was marred with lack of information, poor awareness, resulting in very late diagnosis, allowing low possibility for recovery, leading to poor quality of life. The treatment was more defined by availability of healthcare setup and access to it, making it more location dependent. So the discussions now made it very clear that the healthcare system in LMIC still continue to remain driven by provider-centric and disease-focused thing. So today's discussion clearly highlighted the need for healthcare systems to understand that the care starts at risk reduction phase itself to minimize risks, the need to remain patient-centered and understand their care preferences influenced by various touch points, and technology-based interface to better awareness, patient literacy, early diagnosis, appropriate treatment, and post-treatment and continuum of care, following self-management, guided management principles. This will allow us to remain patient-centric and documenting care pathways to devise suitable strategies to address these identified touch points more intensively will ensure better quality of life. So this has been our collective motto. So thank you so much. I thank my fellow speakers for bringing together their rich experience, IAPG Secretariat for organizing this, and the chairperson for this opportunity, and also for bringing the Asia Pacific Patient Congress to India. Thank you, Kawaldip.
Thank you very much. And I'll ask production to now move us on to the next very interesting session. Thank you, production, and thank you all the speakers.